Welcome to this presentation on the cardiovascular system, specifically the chapter on the heart. This will be the first of three presentations related to the cardiovascular system. In this chapter, presentation, we'll be looking at 19.1 and 19.2, and only a small part of 19.2. So the vast majority of this presentation will come related to heart anatomy, with a little tiny bit on cardiac muscle, most of which you already know. So let's get started with this presentation. So the heart, absolutely amazing. As we move into this chapter, I hope that you will just be in awe of what the heart does and the cardiovascular system in general. I know I always sort of say that. I'm always most enthusiastic about the unit that we're learning, but man, the heart is an amazing organ, and this system is truly remarkable. Chapter objectives. Again, this is for the entire chapter, of which we're only doing a small part. You're going to be stopping right here. So we're going to talk about the parts of the heart. We're going to talk about the cardiac circuit, the blood that passes through the heart and the body. We'll talk about the location, size, and shape of the heart, and we'll finish up with a little bit on cardiac muscle. All this other material from here down is going to be all things that you'll cover largely in physiology. So let's get started with 19.1, and I am going to just have you sit back and just imagine what's happening here. We've got the heart. It is going to beat, on average, 75 times per minute. Now, this is an average number of all individuals on the planet. If you are younger, likely your heart beats fewer times per minute. It's more efficient, it's stronger, it's healthier. As we get older, the number of contractions that your heart undergoes will increase as the heart becomes weaker and less efficient. I should also note that 75 times per minute is essentially is at rest, right? This is not when you're at exercise. This is not when you're stressed. This is your resting heart rate. Now, in order, if your heart's going to beat 75 times a minute, that means that it is beating over 100,000 times a day. Don't memorize these numbers, but just be in awe of them. That means more than 39 million times a year. And finally, over 3 billion times in a relatively short lifespan of 75 years. Each time that your heart beats, it is ejecting or pushing about 70 mils of blood. 70 milliliters of blood is being pumped with each contractile phase of the heart. That means that, again, 70 mils times 75 contractions a minute, that you are pumping at rest about 5.25 liters of blood every minute. Well, I guess we should stop and ask ourselves, how many liters of blood do you have in your body? Well, this is variable, somewhere between 4 and 6 liters. A large person would have the upward numbers of around 6 liters of blood. A more petite person would be back in the 4 to 5 liters of blood. So another way of thinking about this, every minute, your heart and the cardiovascular system are pumping your entire blood volume. Close enough, right? Essentially, your entire blood volume is being pumped around your entire body every minute. If we quantified that by the day, your heart is pumping around 14,000 liters a day. Guys, this is the swimming pool, right? This is a good sized swimming pool. So you are pumping, it's an amazing thing, right, that you're doing. And we're talking in a year, right? You're pumping 10 million liters or 2.5 2.6 million gallons of blood. Truly amazing. And probably even more amazing is that in your body, you have roughly 60,000 miles of blood vessels. And we'll do an entire presentation later related to the cardiovascular system on blood vessels. And we'll learn about arteries and veins and capillaries. But some estimates are even more than 60,000. Some estimates have up to 100,000 miles of blood vessels in the body if you're a larger person. So, truly an amazing system as we begin to break it down into its parts. The animations in Blossom are absolutely stellar. You're not going to find animations of this quality anywhere else. Make sure that you are watching these, spending time to consider them. Guys, they're short. Make sure you're watching them. Make sure you're also entertaining and looking at the questions that are scattered in the chapter. I'm not stopping, as you know, to watch the videos during my presentations. I'm rarely stopping to address the questions, but you should be doing that to assure that you are fully understanding the content. So where is the heart located? It's located in the thoracic cavity in a region called the mediastinum. You know, the mediastinum is that area in the center of the thoracic cavity, essentially the space between the lungs. I always think of it too as the medial area behind the sternum. Mediastinum, mediasternum. It helps you to remember that. The heart is essentially the size of your fist. So again, a larger person is going to have a larger fist and is going to have a larger heart as well. When we take a look at the heart, we see that there is a pointed region of the heart referred to as the apex. Notice that the apex is pointing inferiorly, and what you can't tell here in this picture is that not only is it pointing inferiorly down to the left side, but it's also pointing a little bit anteriorly. So it's pointing outward just a little bit. It's at a slight angle. The apex, again, is on the inferior side. The top of the heart, the superior border of the heart, is referred to as the base. That may seem backwards at first. I agree that it seems that way. Typically, we think of the base as being on the basement, on the bottom. Essentially, the heart is, quote, upside down, if you want to think of it that way. Compared to the lungs, we'll see how it is. Everything is backwards in its orientation. Around the heart, you know this from Lab 1, there is the pericardium. You know the pericardium is one of the 3 serous membranes. Pericardium is made up of 2 layers. Recall there's the visceral layer, which is shrink wrapped to the surface of the heart itself, and the parietal layer, which is lining the wall of the cavity around the heart. We'll discuss more of that detailed in a few minutes. In between those 2 layers, there is a space. That space is the pericardial cavity, and that space has fluid in it, serous fluid, which you know is there to help lubricate the expansion and the contraction of the heart and to minimize any sort of heat buildup or tissue damage that could occur. The heart does sit essentially directly on top of the diaphragm and is connected down. The pericardial sac is also connected directly to the diaphragm as well as to the backside, the posterior side of the sternum. Here we're given a little bit more specific location of the heart. You'll notice again that the heart is largely protected by the sternum in front, not completely, right? This is the right side of the heart that I'm circling now, and the right side of the heart is much more protected, if you will, behind the sternum. The apex is pointing to the left, again, downward and in a forward way. And you can see that is largely protected also by the manubrium. So the manubrium, the superior aspect of the sternum is also protecting tremendously the large vessels that are traveling in and out of the base of the heart. So the aorta and the superior vena cava are in part protected by that manubrium, which you can see the shadow of in this image. If you are going into healthcare, and most of you are, you will, in your future courses, become CPR certified and learn a lot more about CPR. I will not be teaching that as a part of this course, but you are aware that CPR is the rhythmic pulsing compression of the chest cavity that is implemented when the heart stops. If the heart stops, the only way to continue moving blood through the heart is to act as an external force, pushing the blood through the heart manually. This video or this inset goes through the location of the location of where to put the hands as you begin the compressions. Recall too that you are pressing on the sternum and the costal cartilages that are there, and you are aware that the costal cartilage are somewhat flexible because they are made of cartilage, and that occasionally when doing CPR, the sternum or some of the ribs can be broken if not done properly. Even done properly, there is a risk to that, especially in older patients. And that is simply the cost of being a good Samaritan. If you are having to do CPR, hopefully you've kept the patient alive and the rib or sternal breaks are minimal. And I won't be asking you to know the specifics of CPR, but typically you're trying to beat about 100 times per minute to keep blood moving through the heart. So again, the shape of the heart is similar to a pine cone. It's about the same size as your fist, and the size the female heart will be smaller because most women are smaller versus the male heart a little bit larger. The heart of a well-trained athlete can be larger, although I will say now you do not want an enlarged heart. So let me just clarify this. Having a thicker heart muscle can also be a sign of a disease, hypertrophic cardiomyopathy. This is an enlarged heart, and the problem with this is that an enlarged heart is a diseased heart. It is not the same as the skeletal muscles in your body. If you work out your biceps brachii, you know that your biceps can the muscle becomes more prominent, and a bigger muscle is a stronger muscle. In the heart, however, an enlarged heart can actually lead to a less efficient heart, and as a result, the heart is not as efficient. And this is a condition that you'll hear about occasionally, where young athletes will be on the basketball court or on the football field and will just drop dead in a practice where the efficiency of the heart no longer is sufficient. And so this is one thing that I think personally should be tested more sufficiently. When you go in for a sports physical, nowadays they do very little to check the heart. Usually in any larger city, there are some clinics that are set up, especially in the summertime, to help um, better monitor heart function and heart health. And they might put a student through a more significant heart check. But again, typically sports physicals are rather weak or insufficient in looking for this condition. Let's talk about the heart. It doesn't weigh very much. It's a hollow organ, right? It's made up of four chambers. So the human heart, four chambers. There are two atria, plural, one atrium on the right, one atrium on the left. An atrium is a term that simply means the entryway into your home, your church, your business. The entryway oftentimes is referred to as an atrium. The other two chambers, the more inferior chambers, are the ventricles. We'll see that the heart is linked to two distinct circuits in the body. There is the pulmonary circuit. The pulmonary circuit is going to bring blood to and from the lungs. It's in the lungs that the blood will pick up oxygen and deliver carbon dioxide. The systemic circuit is the other more substantial circuit, and this is where you are transporting blood to and from all of the tissues in your body. In this animation, you can see that we have from the right side of the heart, we have blood going. We see this blue deoxygenated blood. We'll come back to that in a moment, but it's going over to the lungs. This represents your pulmonary circuit here on the right and on the left, and or I should say on the left and on the right. Let's make sure we get our anatomical directions correct. And we see the blue blood is going to the lungs. We see a little bit of purple. That purple is representing the mixing of the blue and red blood. Where you see purple in these images, that is where there is gas exchange. And then we see blood coming back through the pulmonary veins, back to the left side of the heart. At this point, those terms may not make sense to you, but they will here in just a couple of moments. So on the left and the right, we have the pulmonary circuit. On the top and the bottom, those represent the systemic circuit. Imagine blood going up to your brain, delivering oxygen, coming back down. Also, blood going down to your lower extremities in the same situation. Make sure you're following, answering these questions, and make sure it's all making sense to you. A large part of your understanding of this unit is, do you know the flow of blood through the heart? Do you know the flow of blood through the chambers, through the valves? And if you know that, then so much of this knowledge is going to be rather straightforward. You've got to know, though, the flow of blood through the heart. And with that, the structures that you find in the different chambers. Is the blood in that particular chamber a deoxygenated blood or a fully oxygenated blood? You probably also want to make sure that you have within your reach red and blue pencils or pens as we progress through Lab 8 and 9. And as we progress through all of this material for Exam 4, you're going to want to have red and blue pencils and or markers for your studying. Red and blue are very significant colors in the cardiovascular system, and you'll understand this more completely as we move forward. So we're going to start talking about that flow of blood. So from the right ventricle, the right ventricle, we're going to pump blood up into the pulmonary trunk. Think tree trunk. Think large tree trunk. And you know that a tree trunk is going to move and split into smaller and smaller branches. And so what we'll see is that the pulmonary trunk is going to receive blood initially from the right side of the heart, and that's going to lead to the lungs and split into the pulmonary arteries. There's a left and a right pulmonary artery. These are going to continue to branch into the pulmonary capillaries. It's in the capillaries where gas exchange will occur, and we will deal a lot more with gas exchange when we get to the capillaries in the blood vessel lecture. Not only are you picking up oxygen, but you're also delivering carbon dioxide in the lungs. And then once that oxygen has been picked up by the blood and by the red blood cells, that blood's going to come back, return through pulmonary capillaries, leave the lungs, and come out the pulmonary veins and come back to the left side of the heart. So, how does the heart receive its blood? The blood is going to leave the systemic capillaries. It's going to leave the body, come back to the heart through two very significant veins. These are the superior vena cava, pretty much bringing blood back from everything above the heart, brain, neck, chest, and arms, and the inferior vena cava, which is going to return blood back from lower places, essentially the lower extremities and the abdominal region. So again, these videos are going to be amazing in helping you. Um, this particular video is about the superior and inferior vena cava, and what you're looking at are, I'm looking at it now, the blue inferior vena cava bringing blood up, and the superior vena cava bringing blood down, both into the right side of the heart. So blood in the inferior and superior vena cava are going to flow down into the right atrium or up into the right atrium. That blood is then going to go into the right ventricle, and we're going to move through the right side of the heart. So let's take a look at this diagram. It's similar to what I showed you a moment ago. You should be able to very soon, maybe not yet, but very soon, you should, with great confidence, be able to trace with your finger this diagram and make sense of it. So as we look at the heart here, this is the apex, this is the left side of the heart. Over here is the right side of the heart. And leaving the right side of the heart out of the right ventricle into the pulmonary trunk. That pulmonary trunk is going to split into to the left and to the right pulmonary artery. It's heading over to the lungs. It's going to split and split and split, and eventually go into the microscopic tissues of the lung where gas exchange is going to happen. What we're sending to the lungs is blue blood or deoxygenated blood. That is shown as blue. Then we see a little bit of purple representing gas exchange, and then the blood becomes oxygenated and is shown as bright red. And you'll understand how red blood cells are capturing and carrying that oxygen, and what actually causes the blood to be bright red when that blood is highly oxygenated. And that blood's going to come back through not one but two pulmonary veins, two on each side, coming to the left side of the heart. And then from the left side of the heart, we're going to pump blood out the aorta, and the aorta is going to split. Some of the blood's going to go up toward the brain and the arms. Again, we see the delivery of red blood. We see purple for gas exchange, and then we see blue blood. So the tissues are receiving oxygen, giving up CO2 as a waste product, and that blood is going to come back from the head, neck, and arms through the superior vena cava, from the abdominal and legs up the inferior vena cava back into the right side. Remember what I said earlier, every minute your heart is pumping a little bit over 5 liters of blood, and you have essentially also about 5 liters of blood in your body. So your heart is pumping that 5 liters of blood every minute through those contractions, through all 60,000 miles of blood vessels in your body. Let's take a look at another diagram. As we look at this heart, notice all the arrows. Um, in this image, note that everything on the right side of the heart is showing as blue blood, as deoxygenated blood. What we see here is the superior vena cava. Here is the inferior vena cava. Kind of wish there was an upward arrow right here. And this blood's all going to come here into the right atrium. We'll deal with the valves later. It's going to come down into the right ventricle. So notice everything on the right side of the heart is blue blood, deoxygenated blood. That blood is going to be pumped out pulmonary trunk, heading to the pulmonary arteries. What this particular image is not showing is here is the left pulmonary artery going to the lung. but there's also a right pulmonary artery over here, not shown, that's going to the right lung. The blood is going to then return from the lungs through these pulmonary veins to here on the left, to not shown on the right. All that blood is draining back into the left side of the heart. Notice that everything on the left side of the heart is oxygenated or red blood from the left atrium down to the left ventricle. When the left ventricle pumps, the blood's going to go kind of a crisscross back behind and come up into the aorta. And the aorta is then going to have three significant branches off the arch, as well as another descending aorta not shown in this particular image that is going to continue to bring blood to the lower extremities. Again, all of this will make more and more sense as we move through this unit. So let's talk about the pericardium. You already know quite a bit about this. This particular image in this video will highlight and remind you of that. I like this image though in that it's showing you the double layer of that serous membrane of that pericardium. Remember that the visceral layer is shrink wrapped right to the surface of the heart muscle itself, and that the parietal layer is the more superficial layer that's wrapped around and lining the wall of the heart. And the space in between is the pericardial cavity that gets filled with serous fluid. Let's go ahead and name the layers of the heart. There are three layers of the heart, and the most superficial layer is the epicardium. You know what that means. Epi, on or upon. So the epicardium is the layer sitting on the heart. Well, just a moment ago, I told you that the visceral pericardium is sitting on the surface of the heart. It turns out these two things are the same. So if you hear visceral pericardium or you hear epicardium, it's referring to the same thing. And you already know that this is a simple squamous epithelium, very thin, right, that is sitting on the surface of the heart. Now, there is another layer of the pericardium that we have not yet seen before, and that is around the heart. In addition to the parietal pericardium, there's also a fibrous pericardium. Imagine that your heart is sitting in a thin leather sac, and that is the fibrous pericardium. It is not the same as the parietal pericardium. Remember that the serous membranes are made up of simple squamous epithelium. The fibrous pericardium is made up of a tough, dense connective tissue. Okay, you are thinking like a sac, like a tough leathery sac around the outside of the heart. And then deep to that fibrous pericardium, that is where you find the parietal pericardium. It's fused on the inside of that. So we'll see a picture of this in a moment. So the classic picture of the heart sitting in a balloon-like substance or structure. Again, the two layers, the visceral layer, shrink wrapped to the surface, the parietal layer, the outside layer. What this picture is not yet showing is that fibrous layer. Again, pericardial fluid in between those two serous layers. Recall back in histology, we learned that the serous membrane is one of the three mesothelia, and that the visceral pericardium and the parietal pericardium are only made up of simple squamous epithelium called the mesothelium. Recall because they are derived from the mesoderm, the middle layer of the early embryo. So let's take a look at the layers of heart. So we're going to take just a chunk right here and blow it up right here. Let's start on the outside. So there is that parietal pericardium. Here's the visceral pericardium. The artist is showing us that it's a simple squamous layer. There's a space in between filled with the pericardial fluid in the pericardial cavity. The thickest layer of the heart is cardiac muscle, and that layer is called the myocardium. If we zoom into this, we can appreciate that the artist has really put some nice details in here, in that we see branched cells, we see striations, and we see the presence of those intercalated discs. So there's nothing new there that we're not fully aware of. We also zoom in and we see that there's a lot of innervation, or there's a lot of blood vessels also traveling inside the heart. And then the inside layer, the layer that is touching the blood that is inside the heart chambers, that layer is called the endocardium. These words should make sense to you. Epicardium, aka visceral pericardium. Make sure that you realize those are the same thing. Visceral pericardium and epicardium are the same. Myocardium, the muscle layer of the heart, and endocardium. Remember, endo means within. So the endocardium is the layer on the inside. And it is also, look at this, it's also made up of a simple squamous epithelium. So what can go wrong? Tamponade is when there is excess fluid in that pericardial space. So look at this heart. Imagine this almost looks like a heart in some sort of like a Meyer bag, right? In a grocery bag, a plastic bag. And there's fluid that has built up in between those two serous layers. This can be a real problem in that it's going to impede the ability of the heart to contract forcefully. And this can mimic all sorts of issues, shortness of breath. And this would certainly be something that would need to be addressed in the emergency room. Oftentimes, they will drain this extra fluid off and provide other care until they figure out the cause of that fluid accumulation. Sometimes it's an infection. Let's take a look at the surface of the heart. Again, we can't see the chambers of the heart, so let's take a look at what we can see on the surface of the heart. I'm going to go down to this image and let's get ourselves oriented. So if you were to open up, you're looking at someone and you were to crack open their chest and take a look into their body, you would see the heart. You would have to get past that pericardium. You'd have to crack through the and get past behind the mediastinum area, behind the sternum and the ribs, and you would see this pointed region. Now, there's quite a bit of variation here. In some individuals, the apex is really quite pointed. In other individuals, the apex is a little bit more rounded. The pictures you'll see, though, this is about the sort of pointy structure that you'll see in most images in textbooks. So that's the apex. You know, that's pointing down toward the left side of the body. What else are we seeing externally as landmarks? There are going to be two flappy structures. These flappy structures are called the auricle. Now, you may recall that in the ear, the flappy part of your ear is called the pinna, Pinna, or the auricle. And so this gives us a visual of this. So there's a flappy portion of the heart sitting on top of both atria. So there's a right auricle associated with the surface of the right atrium, and there's a left auricle over the left atrium. So those are really nice external landmarks. We also see the superior vena cava and the inferior vena cava. These are two of the four great vessels. So when we look at the heart, there are four great vessels that are very visible. These are called great vessels because they have the greatest diameter and they directly connect to the heart itself. So two of these are veins. That is the superior vena cava and the inferior vena cava. The other two great vessels are the pulmonary trunk and the aorta. So one, two, three, four great vessels, about 1 inch in diameter, very large vessels directly connected to the heart. Two are receiving blood. So the large veins, the superior and inferior vena cava, are delivering blood to the heart, and the arteries are sending blood away. If you're going to the pulmonary circuit, you're sending blood to the lungs through the pulmonary trunk. If you're sending blood to the systemic circuit, you are sending blood through the aorta. Notice also the color difference. The pulmonary trunk is sending deoxygenated or blue blood from the right side of the heart over to the lungs to become oxygenated. The left side of the heart is sending blood already returned back from the lungs, oxygenated, and is forcefully pumping blood up and out of the heart through the aorta to all of your body systems, aka the systemic circuit. On the surface of the heart, there are some little patches of fat that you'll see. There are also a number of vessels, and we'll name these later on, but there are coronary arteries. The coronary arteries would be red in color. These are the arteries that, if they become clogged or for some reason should undergo an aneurysm, a bursting, they would lead to a heart attack because the heart is no longer receiving blood in the sufficient levels that it requires. We talked about stroke before. We know that the brain is very sensitive to low oxygen levels. We also know that the neurons do not regenerate if once they die from that lack of oxygen and lack of nutrients. Cardiac muscle is very, very similar. Cardiac muscle is also extremely energy dependent, must have a constant supply of oxygen, must have a constant supply of nutrients, and cardiomyocytes or cardiac muscle cells do not regenerate. Whereas if you tear your skeletal muscle, in fact, when you work out heavily, you are doing micro tears to your skeletal muscle. And when skeletal muscle regenerates and rebuilds, it creates thicker muscle. In the cardiac muscle, when cardiac muscle cells do not receive oxygen or nutrients, those cells die. And once those cardiac muscle cells die, they no longer can contract. They don't replace themselves. And so after a myocardial infarction, that is when there's a lack of oxygen going to a part of the heart muscle, those cells are no longer contributing to the forceful contraction of the heart muscle. The larger the area of the heart that is damaged, the less likely the person will recover from that heart attack. So if the blockage is very small and the damage is very limited, a person will likely survive that heart attack and may have a normal life thereafter. If it's a moderate amount of muscle, then they may have some restrictions following that heart attack, the inability to exercise, just not able to keep up if they're super active. And then if a more significant component or critical parts of the heart muscle are destroyed from that heart attack, the person likely will not survive that heart attack. We also see here the pulmonary trunk coming out, the pulmonary arteries, and the two pulmonary veins. There'll be two coming in from the left side here. There'll be two coming over here from the right side as well. So these are all some of the external structures that we see. Lastly, there are some grooves in the surface of the heart. We saw the same name given to the brain structures, sulci, a sulcus. So in the very front of the heart, anterior side, going right down the middle, essentially between the right ventricle and the left ventricle, there is the anterior interventricular sulcus. It's a groove, a sulcus, that's found between the ventricles, right? Interventricular on the front side. So anterior interventricular sulcus, and we see that these coronary arteries are traveling and are protected in part in that groove. There's also a coronary sulcus. The coronary sulcus travels all the way around the heart at a unusual angle, and this coronary sulcus again is a protective groove for some of the critical blood vessels. I didn't say it earlier, I'll say it now. You have cardiac, you have these coronary arteries, and then you have cardiac veins. So the red structures are the coronary arteries, the blue structures are veins. They're called the cardiac veins, and they are returning blood back to the heart once they've delivered oxygen and picked up CO2 from the heart muscle itself. So make sure as you are going through the chapter, you're stopping to label different activities and that you're also looking at this in the lab manual. Let's look at a posterior view of the heart. Again, we get a different perspective, but we see the two pulmonary veins on the left, the two pulmonary veins on the right. Of note that we could not see before, there is a very large vessel on the underside posteriorly called the coronary sinus. The coronary sinus is receiving all of the blood from all of those blue cardiac veins. They're all draining up and heading into this sinus. You know what a sinus is, a large space. So this is a large space. It happens to be a vessel. The coronary sinus is receiving all of that deoxygenated blood from the entire heart. And what we'll see in other pictures is that the coronary sinus returns this blood also into the right atrium. Not obvious here, but it is the third way by which blood gets back into the right atrium. Also on the posterior side, there is a posterior interventricular sulcus. So on the underside and the backside, there's another groove that helps to protect some vital coronary arteries and cardiac veins. Let's go back and take a look at the layers again. There's a beautiful animation here that will go through those three layers for you. We've already said them. Let's just say them again. That the outermost layer is the epicardium, aka the visceral pericardium. The middle layer, the thickest layer, is the myocardium, mostly cardiac muscle cells. Blood vessels traveling through there as well. Again, a lovely animation to make sure you understand and appreciate the myocardium. Another animation that walks you through all of those layers. And then the inside layer is the endocardium. The heart is an amazing pump. When the ventricles squeeze, the muscle fibers, right, the cardiac muscle fibers are not just arranged in a straight line, but are arranged in some squeezing pattern. So when the heart contracts, the muscle cells cause not only a shortening, a constriction, a contraction of the heart muscle, but also a twisting motion. Imagine you are wringing out a mop, right? And you need to wring that mop out. You're going to put it in the bucket, you're going to wring it, and you're going to sort of twist that mop head and squeeze all that water out. Essentially, that's what's happening in your ventricles and in your atria. The muscle cells are squeezing as well as twisting to push as much blood forcefully out of the heart as possible. When you take a look at the heart, you'll also, I think, be very struck when you do your heart dissection at the difference in the thickness of the ventricles. The left ventricle is a far more muscular chamber than the right ventricle. And you can see this is the atrium, or this is sort of the apex. So this is the left ventricle here. If you were to stick a pencil or a scalpel up into the apex, you would be at the left ventricle. That's another really good external landmark to get your orientation. So the apex, you poke right there, you are in the left ventricle. And notice that the left ventricle has a smaller space, a smaller lumen, a smaller volume that can hold in there, and a thicker myocardial layer. When the left ventricle squeezes, it is going to force blood up and out of the left side of the heart, up through the aorta, and it must push it with enough force to push that blood up against gravity, up the vessels against gravity, all the way up to the brain. Right? We all are aware that the brain is a constant needy organ for blood and oxygen. And it must also make sure that blood gets pushed all the way to the lower extremities into the arms. Gravity helps a little bit with those areas, but the left ventricle is under much greater pressure. So when you hear about blood pressure, right, it is really the pressure caused by the contraction of the heart pushing out through the blood vessels, and the blood vessels have a certain amount of pressure also on them, sort of like a hose as it carries water. The greater the pressure, the greater the turgid nature of that hose. Now the right ventricle has a bigger space and is not as thick, because when the right ventricle squeezes, it only has to send blood a short distance over to the lungs. So it is not pushing blood out with as much force at all. It's important to keep in mind or to appreciate that the right heart and the left heart are not the same. You're seeing that over and over now. I just haven't said it yet. Just like we learned that the right brain and the left brain, the two hemispheres, are not equal. There are some specialized roles in the right brain versus the left brain. So too, the heart, the left heart and the right heart, and cardiologists and those who work with the heart will talk about the left heart and the right heart, because some will say that the heart is really a double pump sitting side by side. The right side is pumping blood just to the lungs. The left side is pumping blood in a coordinated way, but is sending blood under much greater pressure to the rest of the body. I also want you to think about the heart as a pump. And if you've ever been around a pool or a hot tub, you might know that there's a pump involved, right? Pumping the blood, the water, and the heart is a pump. So when we think of pumps, we normally think of things being pushed, right? When the heart squeezes, contracts, blood is pushed under great force out of the heart. But not only do pumps push, pumps also suck. So we want to remember that the heart is not only pumping blood out, but the heart is also sucking blood back into it. Our circulatory system is a closed system, just like a pool, right? Unless there's a leak in the pool or a leak in the hot tub, it's the same water that is circulating, and you've got water being sucked into the pump and you have water being pushed out of the pump simultaneously. So again, that inner layer of the heart is the endothelium and the endocardium, I should say, and is continuous with the blood vessels leaving the heart. You may recall that lining your blood vessels, there is a layer of simple squamous epithelium referred to as the endothelium. Now, why is that layer called the endothelium? Because it's derived from the endoderm of the early embryo. We've seen that before. So that simple squamous, the endothelium that lines your blood vessels, it's the same thing, lining the inside of your heart wall. That is the endocardium. So everywhere where blood is, right? Blood is in your chambers as being pushed out through the blood vessels. The blood is always up against a layer of simple squamous epithelium. So we've looked at the outside of the heart, we've looked at the layers of the heart. Now let's take a dive into the internal structures of the heart. Again, an excellent video to help you appreciate structures. If you do essentially a coronal or a frontal section through the heart, I should back up here and ask you for a moment. If you were asked, and you will be asked this in your heart dissection, to create a frontal or a coronal slice through the heart, how would you do that? How would you orient the heart to then do a coronal or frontal slice? Well, as we've described before when we did the eye dissections, you would place the heart as if it were in your body in anatomic position. And just like if you were to do a coronal section and you were going to make anterior and posterior slices, so too you would cut the heart in front and back sections to create the coronal section. And depending upon exactly where you make that slice, you would see something like what is here in this animation. And you would notice that there are septa, right? Septa are many septums, and these are dividers between the chambers. So here we see the right side of the heart. Notice the heart wall is not as thick as it is over here. The left side is a much thicker wall, and the left side over here, the left ventricle. So the right ventricle, blue blood going to the pulmonary circuit, left side, red blood going to the systemic circuit. There are valves in the heart. These valves are going to assure that blood only moves in one direction. Now, there's two different types of valves in the heart. There are the atrioventricular valves, and that is what's prominent here. You have on the right side the right atrioventricular valve. Don't make this hard, my friends. It just tells you that it's a valve on the right side between the right atrium and the right ventricle, atrioventricular. Now, this valve, and we'll see it again in a moment, has three parts to it, and so it's also called the tricuspid valve. On the left side, we have the left AV valve, the left atrioventricular valve. Again, it's between the left atrium and the left ventricle. It only has two main parts to it, not obvious in this particular cut, but it is also called the bicuspid. It's also called the mitral valve. You'll be learning about those quite a bit as we move forward. We also have two other valves. There is the pulmonary valve. This is referred to as a semilunar valve. And back behind here that we can't see right now is the aortic valve. So four valves. The first, and this animation will walk you through those valves. So again, we have two atrioventricular valves, left and right, nicknamed the tricuspid and the bicuspid. And there are two semilunar valves. These are the valves that go into the pulmonary trunk and into the aorta. In addition to valves, in addition to the septa, there is also a fibrous skeleton of the heart. You appreciate that the heart is a hollow organ, and yet the heart has structure to it. We wouldn't want the heart to collapse on itself. And so there is a fibrous skeleton. This is not necessarily like our bony skeleton, but it is a structural skeleton, gives the heart its shape and helps to maintain its shape. It is largely made up of connective tissue, and we'll see that as we move forward through here as well. Let's take a look here in the lab. You will be asked to not only dissect a heart, but you'll also be asked to trace the flow of blood through the heart. You'll be asked to do this in the models. You'll be asked to do this in your head. You need to be able to do this. So let's take a look at this. Let's go through this slowly. So we're going to see red and blue arrows to indicate the flow of blood from one chamber through valves into the next chamber. So we see blood coming into the right atrium. We've got to start somewhere. I will typically start with the right atrium. We see right atrium receiving blood from the superior vena cava and up from the inferior vena cava. You can't see it here, but there's also an opening in the right atrium that receives blood from the coronary sinus. Blood from the right atrium. The right atrium is going to squeeze a little bit. Blood is going to pass down through the tricuspid valve, aka the right atrioventricular valve, down into the right ventricle. The right ventricle is, um, what do we see in the right ventricle? We're going to see that tricuspid valve. We're also going to see three significant papillary muscles. You know, papillae means nipple shaped. So these three nipple shaped muscles coming off the wall of the ventricle. And these three papillary muscles are going to be attaching to three significant parts of that tricuspid valve strung down by these cords called the chordae tendineae. Also, at the bottom of the heart, there is an arrangement of the muscle tissue referred to as the trabeculae carneae. Remember that spongy bone is called trabecular bone. Imagine spongy bone, just a bunch of mazes, little spaces, and that's what this is referring to. There's all these little crevices down here in the heart muscle, trabeculae carneae meaning meat. So basically, meat with little holes, little trabeculae. We now, when the right ventricle is going to squeeze, going to leave up through the pulmonary valve. This will be called the pulmonic valve, the pulmonary valve. You'll also hear the pulmonary semilunar valve. Blue blood is being pumped into the pulmonary trunk. Pulmonary trunk is going to split then into the left and right. Right's not shown. Pulmonary arteries heading off to the lungs. In the lungs, the CO2 is going to be dropped off, oxygen would be picked up, and blood will come back to the left side through pulmonary veins. Two on the left, two on the right, not shown. That blood is coming back into the left atrium. From the left atrium, blood's going to pass down through this valve. This valve has two main parts. It's called the mitral valve, the bicuspid valve, or the left atrioventricular valve. In the heart, just remember, you try it before you buy it. So the tricuspid comes before the bicuspid valve. You still see chordae tendineae, but there would only be two significant papillary muscles on this side, two papillaries over here for the bicuspid, three papillaries on the right side for the tricuspid valve. The left ventricle is surrounded by a much thicker layer of myocardium. This chamber is going to pump under great force, push blood up through the aortic valve into the aorta. We have the upward portion is the ascending aorta. Then there is the aortic arch. And then that's going to come down the back side of the heart. And many books show the descending aorta here, where I'm pointing at the bottom of the heart. So again, keeping track of the order of the chambers, the valves, the landmarks along the way, which side is carrying blue blood, which side is carrying red blood, the number of pulmonary veins and arteries, all of that is critical that you have a solid understanding of this, and you should be labeling and reviewing every image you get and watching every animation you can until this clicks like the freckles on the back of your hand. So we're just going to walk through this step by step. I went through it with that image. I'm going to say it all over again. In the right atrium, right, we're receiving blood from the systemic circulation. Two major veins, the superior vena cava and the inferior vena cava, and the coronary sinus. Three ways by which blood gets into the right atrium. Again, the superior vena cava is bringing blood from everything above the diaphragm, the head, the neck, the upper limbs, the thoracic region, and it empties into the top part of the right atrium. The inferior vena cava is going to drain blood back up from things below the diaphragm, lower limbs, abdominal pelvic region of the body. It's also coming into the right atrium, but more toward the inferior side of it. And then on the back side of the right ventricle is the opening for the coronary sinus. And you'll see that in the models upstairs quite nicely as well. There is in the interatrial septum. So the divider between the right and left atrium, there is a depression, an indentation called the fossa ovalis. Fossa, you know what that means. Fossa is an indentation. We saw like the iliac fossa. And oval is just the reshape of it. So the fossa ovalis is what you have in your heart right now, right? It is what it is. So the fossa ovalis is a depression. We'll figure out where that is and why that is later on. The underneath the right auricle has some pectinate muscles. Uh, we'll see the pectinate muscles in the model upstairs. You'll see them in the drawings. These are just sort of an arrangement of the muscle fibers in the right atrium and the right auricle. Over on the left side, we won't see the pectinate muscles as much in the atrium, but only in the auricle itself. Again, everything that's receiving blood on the right side is blue blood. Blue blood, blue blood, blue blood. Now, as blood is coming into the right atrium, the tricuspid valve will be closed, right? That will be closed as blood comes into the right atrium. Now, that tricuspid valve is going to open, and blood is now going to travel down to the right ventricle. There are chordae tendineae, literally meaning tendinous cords. You've heard of heartstrings. This is what we're referring to, right? And these chordae tendineae are associated with the flaps of the atrioventricular valves. Now, the right atrioventricular valve is nicknamed the tricuspid. There's three parts, three sets of three flaps and three sets of these chordae tendineae going down to each of the three primary papillary muscles. We can see that here, the chordae tendineae, very strong tendinous cords attached to the papillary muscles. And then here you can see that at the base of the ventricle, you see this sort of spacey area in the muscle wall that is a trabeculate carne. From here, the blood is going to pass out of the right ventricle. It's going to contract under moderate force. It's going to go into the pulmonary trunk, branch into the left and right pulmonary arteries, one on each side, carrying that blood to the lung. This blood will go through the capillaries of the lung. We'll figure that story out more in detail later. It will drop off the CO2. It'll pick up oxygen. The blood will then come back through a series of pulmonary veins. And there'll be two on the left, two on the right, returning blood over to the left atrium. This blood will be bright red. It's the most oxygenated blood you have. It's just coming straight from the lungs. From the left atrium, blood is going to go down through the left atrioventricular valve, aka the bicuspid, aka the mitral valve. Bicuspid, therefore, only two main papillary muscles on the left. And these valves are there for a couple of reasons, but primarily to assure that blood only moves in one direction. In a happy, healthy, well-functioning heart, the two atria are contracting at the same time, followed briefly by a short pause, and then the two ventricles are going to squeeze at the same time. The blood moving through the valves is to assure that blood only moves in a unidirectional way through the heart. If these valves are faulty or leaky and blood is being leaked back through the valve in, quote, the wrong way, that is referred to as a murmur. And a murmur is simply a backflow of blood. A minimal murmur is okay. A small murmur is okay. The majority of the blood is moving in the right direction. But if the valve is so weak or is so dysfunctional that too much blood is going backwards, that of course means that blood's not going forward. That blood that's going forward is necessary to serve all of your body's tissues with oxygenated blood. And so a faulty valve must be addressed. And we'll see some pictures later on about how valves are replaced nowadays. So again, two semilunar valves, two atrioventricular valves. And if we take a look here, just at the valves in isolation, I think it's pretty obvious which one is the bicuspid valve. The bicuspid valve is the only valve where you only see two significant cusps or points, right? You see two parts. That's the bicuspid, aka the mitral, aka the left atrioventricular. The tricuspid valve over on the right side, you see three distinct regions. There would be three distinct regions of chordae tendineae with three distinct papillary muscles. The semilunar valves, both the pulmonary and the aortic, are more difficult to distinguish from each other. They look essentially identical. But if I were to ask you of these four valves, which one is the bicuspid, you should have no trouble identifying it. Now, let's think about what happens as blood leaves the right and left atria. As blood leaves the two atria, the atrioventricular valves will be open. Blood is going to come down, as this picture is showing us, down into the ventricles. This is only showing us the left side, but it's also happening on the right side at the same time. Now, once blood is down into the ventricles, now those atrioventricular valves are going to close. That means that blood can't go back up, for example, from the left ventricle into the left atrium. Now the semilunar valves will open up, the aortic valve and the pulmonic valve. And now blood will be leaving out the ventricle under force through those semilunar valves. So again, we see the valves are taking turns, opening and closing, opening and closing. There's a number of things that can go wrong with the valves. There are bacterial infections, there's inflammatory responses, there's just anatomical damage. So if we look in this picture at the artist rendition, we can see this valve looks pretty rough, and we can see that there is a bacterial infection on this, is what the artist is trying to show us here. And this valve would perhaps be damaged to the point where it's no longer functioning well, and blood is going backwards, right? That murmur idea. And so what can we do? Well, now here's a nice video showing that valvular regurgitation, aka backward flow, or the murmur flowing backwards. And if this happens, it's now possible to replace valves. It's done pretty routinely. And the book chapter goes through a number of really cool animations and telling you a lot more information than what I'm going to hold you for. But I want you to appreciate, if a valve is going to go bad, if you're going to have a bad valve, which of your four valves is likely going to be the first one to weaken? And I want you to be thinking about the force that the valves are having to work against. So as we've described, the left ventricle is working under far greater pressure than the right ventricle. And so when the left ventricle squeezes, the mitral valve, aka the bicuspid, is having to work against this pressure, pushing up against it. Ideally, all that pressure is pushed up through the aortic valve, but the mitral valve, as you can appreciate, is working very hard to withstand that pressure when the valve is closed. Now, the tricuspid valve, right, is not having to guard against that much pressure. And so if someone's going to have valvular disease or a valvular issue, more likely you're going to hear about mitral valve issues, because it is the one that is working the hardest to stay closed. And we can replace faulty valves with mechanical valves. Sometimes they're metal, sometimes they are. There's a couple of different versions of these. Um, there's also a situation where the valve may not be leaky, but it may be very narrow. And this stenosis, a narrowing of the valve, would cause issues with flow of blood through the heart as it normally should. So again, lots of ways that a surgeon can go up and open up a valve that is stenotic, that is narrowed through a catheter sort of situation like this, and a balloon, and expand that balloon and open up that valvular space. We can also go up and do surgical repairs of the valves. So it's really, really cool what is being done nowadays. Again, I won't be holding you responsible for the repair of the valves, but I want you to appreciate the significance of those valves. Let's talk about coronary circulation. This is the blood vessels that are traveling on the surface of the heart, and I introduced the coronary arteries earlier. You will be introduced to those here now. Then I'll mention the names of the four main coronary arteries, and then in lab 9, when you get to your second cardiovascular lab, you will once again be naming these arteries and veins, and you will learn to name them again in lab 9. So the coronary arteries are supplying blood to the myocardium, to the heart muscle, and to all parts of the heart. And let's make sense of this. So, as blood is coming back from the lungs, it's going into the left atrium, down to the left ventricle, and then that blood is going up through the aortic valve, up into the aortic arch. As soon as, let me go to this picture, as soon as blood comes up through the aortic arch, here is the beginning of the aorta, the ascending aorta, right where I'm drawing a circle. That's where the aortic valve is. And that aortic valve, as soon as that fresh, red, oxygenated blood comes up, the first thing that happens is that some blood is going to travel off to the right and some blood is going to travel off to the left. These are the right coronary artery and the left coronary artery. And these arteries, I think you'll agree, are receiving the freshest, most oxygenated blood that the body has available to it. And these coronary arteries are going to come around. Now, this right coronary artery is traveling through that sulcus. And we're going to see that the right coronary artery is going to split into two main branches. One of those branches is called the marginal artery. And when you look at this view, I always remember the marginal artery is coming along the bottom margin of the heart. It's on the right side, right? Do you agree we're on the right side? And right side, right margin, or the marginal artery. The marginal artery is only on the right side. Now on the left side, the left coronary artery, it's going to split into the anterior interventricular artery. Right, that's this one right here. And recall earlier we saw that the anterior interventricular artery lies protected in a groove called the anterior interventricular sulcus. And also, the second branch, or the other branch of the left coronary artery, is the circumflex artery. And we see it kind of circling around, circumnavigating, right? Circle, flexing around the left auricle. Okay, so the circumflex flexes around the top right here. So the right coronary artery splits into the marginal artery. Let's go down. And the right also splits into the posterior interventricular artery. So know that the main branches of the arteries are as follows. The right coronary artery splits into the marginal and the posterior interventricular, and the left coronary artery splits into the anterior interventricular artery and the circumflex artery. That blood is going off to the heart muscle, delivering oxygen and nutrients. These series of cardiac veins are then returning that blood. That blood comes back to the large coronary sinus. And again, the coronary sinus shown soon here in the picture, is returning blood also to the right atrium. So for now, just know that those arteries, name those coronary arteries. So really there's six to know, the right and left, plus their two respective branches. Again, if those coronary arteries get blocked, then you have a heart attack, right? A myocardial infarction. Myocardial, right? Myocardium, the heart muscle. There's an infarct. There's a lack of oxygen going to that region. There's a lack of oxygen that's called ischemia or hypoxia. Either one results in a lack of oxygen to that very needy heart muscle. Um, this can be caused from a buildup of plaque. Athero is a prefix that you know from our vocab, meaning fat. Sclero means hard. So atherosclerotic plaque is basically hardening of the arteries, hardening of the fat that is lining these vessels. And we know that that is caused by combination of diet, lipids, stress, inflammatory responses in the body over the years. It's also possible that if there is a small blood clot that forms in these vessels, um, that in itself may not be a problem, but that plaque, if it ruptures, then that can be sent up to the brain and that can lead to a stroke. So there can be a plaque buildup in the coronary arteries that then can go up and cause problems in the brain or in other areas of the heart itself. In an acute MI, right, in sudden onset, typically pain in the chest, radiating down the left arm is more common in males, not necessarily in females. Sometimes females will complain more about back pain or indigestion. And so women actually are less likely to get to the emergency room while they're having a heart attack because they don't recognize the early signals or the early signs of a heart attack. In addition to the pain, there can be difficulty breathing, shortness of breath, an irregular heart rate, nausea and vomiting, again, more common in women, sweat, and essentially fainting as well. Any or all of them can be present. You get to the emergency room, they'll hook you up to an EKG, they'll look at the electrical activity of the heart, they'll also take a look at enzymes in the blood. The heart muscle, when it is distressed, will send out molecules into the bloodstream that can be picked up in the blood. And those increased enzyme markers, protein markers, are also a sign that a patient has had a heart attack. Now, nowadays, we know aspirin can break up clots, and aspirin can also help in some situations. There's also medication called nitroglycerin, which was historically people walked around with nitroglycerin pills. Nitroglycerin is a vasodilator. So if you have a partial blockage of your coronary arteries and you feel discomfort or pain in your chest, 50, 60 years ago, it was common for people to walk around with nitroglycerin pills. They would pop a pill under their tongue, it would dissolve, it would open up the airway and restore the blood flow to the heart. Um, Typically nowadays, though, if someone does have that sort of blockage of the heart, it's called angina. Typically, now we will not wait for it to become worse. We will now go in and do a number of procedures to open up those blood vessels. It's interesting that the mechanism of nitroglycerin went on to become known as a major vasodilator and is also used, for example, with erectile dysfunction. It's the same science essentially behind the dilation of the blood vessels here as it is in issues with ED. So the coronary arteries are delivering oxygenated blood to the heart muscle. coronary veins are returning that blood back, and there's a great cardiac vein, a middle cardiac vein, and a couple of others. You'll see these in the lab, and you'll name these as well. They all drain back into the coronary sinus. Here you can see what's called an angiogram. An angiogram is some dye injected, and you can see that dye is here restricted, leaving the heart, and there is a blockage. So this would be a blockage going to the left common coronary artery. This would be a significant problem because you are cutting off blood to half of the heart. And then here you see another restriction of the circumflex. I'm not going to ask you to label these in this circle, but you can see that there's two places where the restriction of blood is minimized. If you hear of someone going to the emergency room with chest pain and they are rushed into the hospital, and within that next few hours they undergo 4 bypasses, right? A triple bypass or a quadruple bypass. What they're telling you is that they're a very fortunate individual, that they went into the emergency room, the department with chest pain. They underwent some testing. They saw 4 areas where vessels were restricted, and they literally go in and they bypass those 4 areas. Now, there's a couple of different things that can be done for this, but one way, right, you go in, you've got some partial blockage, you got some discomfort, some pain, you go to the ED, they do some angiogram. Angina, I mentioned that a moment ago. Angina is a partial blockage of a coronary artery. You might only experience pain when you're shoveling or exercising. And again, this is where people would take the nitroglycerin tabs. Nowadays, we usually don't wait for this to be done, but we'll go in and we'll do an angiogram. We'll map the blood vessels around the heart, and we can go in with a catheter. They'll bring the catheter up the leg or up the radial structures of the arm, or up through the leg up into the heart, and they'll open up the vessels, do a little balloon angioplasty, and they'll basically put a stent in. A stent is basically chicken wire, right? Going up there, placing some chicken wire along the vessel, opening up a balloon and pushing that open and keeping that plaque that's accumulating pushed off to the side and opening up that airway. Now, if it's concerned that this plaque is solid, the plaque can be soft or it can be hard, and they can see that a little bit in the imaging. But if it's a really crunchy, calcified sort of plaque, you would not want to do a stent because those crunchy pieces of plaque could break off and cause problems elsewhere. So instead, they'll literally go in and do a bypass. And in a bypass situation, we're going to take a vein from another part of your body and literally bypass the broken vessel. So we're going to rewire around that blockage area with a bypass. So again, a double bypass, they've bypassed 2 arteries. If it's a triple or a quadruple or quintupler, right? Then they have done that with 5 vessels. And these bypasses are extremely successful. They're rather routine nowadays, and people are living for years post bypass surgeries and post stents. So that brings us to the end of 19.1. Have just a couple more minutes to go. Make sure you are watching the animations, answering these questions. Every one of these questions is something you should be able to answer with confidence before exam number 4. We're only going into the first little tiny bit of 19.2, and there's really nothing new here for you. This is just a quick reminder of cardiac muscle structure. Recall, we discussed that heart is autorhythmic, that there are cells in the heart itself that are sending the signals out, telling the heart to contract. We know that the central nervous system, specifically the autonomic nervous system, can modulate the heart rate, turning up or down. Recall, sympathetic's going to turn it up, parasympathetic's going to turn it down. And we know that hormones and stress can also cause your heart rate to go up or heart rate to go down. There are two basic flavors of cells, of cardiac muscle cells. We're not going to learn about the specifics, but there are the regular contractile cells. These are the cells that are forcefully contracting in order to cause the squeezing of the heart muscle. And then there are also conducting cells. These are the cells that are setting that pace, or setting that pacemaker. These are the cells sending out the electrical signals, telling the heart to contract. You already know this. You know that the heart has intercalated discs, and you know that these intercalated discs are necessary in cardiac muscle for the electrical signal to travel very, very quickly. You also recall from our conversation in histology that cardiac muscle is striated. There is still sarcomeres. There are still overlapping actin and myosin myofilaments making sarcomeres. And but recall that the cells are branched. So we see branch cells. We see many, many mitochondria. We see the intercalated disc here. We see the intercalated disc here in the micrograph. You can see those branchings really, really clearly here. And recall that intercalated discs are nothing more than a combination of desmosomes, connectors between the cells. So here we're seeing we're seeing one cell on the left and one cell on the right, and these cells are connected through the intercalated disc. Desmosomes helping to hold those cells tightly together. Remember, desmosomes are found where there's tissues under high stress. The heart is contracting forcefully, 75, 85, 120, 150, 160 times a minute when you're exercising. Lots of stress. We need those reinforcers and gap junctions. Recall back in epithelial tissues, we talked about how gap junctions are an open channel through which nutrients are shared. But in the cardiac muscle, the major job of those gap junctions is to allow electrical signals to travel very, very quickly from one cell to the next. So, as we've described, when the two atria are contracting, and we're gonna stop right here, guys. This blue line, don't go any further than this blue line. But I'm just gonna borrow this picture for us to see this, to describe the intercalated discs. So here's your right atrium and your left atrium. The two atria must squeeze together. They must contract at the same time. There must be total electrical coordination within the heart. So the two atria are going to squeeze. And then, shortly thereafter, fraction of a second later, the two ventricles are going to squeeze again at the same time. Lub-dub, 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 lub-dub. That's your heart, right? And the lub-dub is simply the closing of the valves. So lub is the closing of the atrioventricular valves. And dub, the second sound that you hear with the stethoscope, when you put a stethoscope to the chest, you hear lub-dub, lub-dub. The second sound is the closing of the two semilunar valves. So we got closing of the valves. You can literally hear that percussive closing of the valves through the stethoscope. And without the intercalated discs, the electrical signal would not travel through all of the contractile cells of the two atria at the same time, and therefore there would not be a coordinated squeezing of the upper chambers, and then again, the coordinated squeezing of the lower chambers. You are going to learn about the conduction system of the heart a lot in physiology. You'll learn how to read EKGs. You'll learn how those electrical signals travel through different nerve structures within the heart. And you have lots and lots to learn about that phenomenon. And that's a really exciting component of physiology. So that brings us to the end of all things discussed here in chapter 19. Again, mostly 19.1 with just a little bit of 19.2.